One moment, let me see if it's recorded. Okay.
Thank you so much for having me here today. I'm so excited to get to talk to you all a little bit about endovascular thrombectomy in the extended window. So far on our site visits, we've been very excited to see that more of your facilities are implementing thrombectomy at their site. And we have reviewed some of their protocols and have seen that current protocols are fast tracking patients out to 6 hours. So I think this hopefully will be a relevant talk for those facilities to maybe consider extending it out to the 24-hour window. I have no financial disclosures. So we'll be talking today about large vessel occlusions, which are very common. About 40% of all ischemic strokes are due to large vessel occlusion. And the mechanisms are intracranial atherosclerotic disease, extracranial large artery atherosclerosis with atheroembolism, cardioembolic or cryptogenic etiologies. And we know that large vessel occlusions have higher rates of death and disability when compared to small vessel disease. So one study that I reviewed suggested that LVO have a mortality rate of 26.2% at 6 months compared to 1.3% in non-LVO strokes. So, another key point is we know that successful opening of the vessel is associated with significantly improved outcomes. So this is an important topic. Our current acute ischemic stroke therapies are thrombolysis, so clot-busting medication given IV, either alteplase or at our facility we're using tenecteplase, and then endovascular thrombectomy with either centrifugal or aspiration catheter. And just for some kind of context for this discussion, I want to review a little bit about the history of alteplase use. So it was really first approved in the States for use in acute ischemic stroke in 1996 after the NINS trial and ECAS trials showed benefit out to 3 hours. And then in 2009, the window was extended to the 3 to 4.5 hour window for carefully selected patients after ECAS 3 and these other landmark trials showed benefit in the extended window. Just a couple eligibility highlights. Even though the window for thrombolysis has been extended to the 3 to 4.5 hour window, we know that it's more effective when it's given earlier. So the number needed to treat for functional independence when given at less than 1.5 hours is 3.6 versus in the 3 to 4.5 hour window, it's almost double at 6. So time is very important. So there are some challenges with thrombolysis, particularly in the LVO population. So there's a narrow therapeutic window of 0 to 4.5 hours. Many patients aren't able to present to the hospital within that time window. Many patients don't qualify because of contraindications on our checklist. And then even if patients do qualify for thrombolysis, it doesn't always work well in our LVO population. So this was a registry of about 2,000 patients with large vessel occlusion from 9 endovascular thrombectomy capable sites in the United States. And they found in their registry that about 60% of patients with large vessel occlusion did not receive thrombolysis. And the most common contraindications were extended time from last known well beyond 4.5 hours. So about 60% of patients did not qualify based on time. And then about 15% didn't qualify because of being on therapeutic oral anticoagulation. And then with our large vessel occlusion patients, there's actually a pretty low recanalization rate with thrombolysis. So for the middle cerebral artery, the predicted recanalization rate is around 25 to 35%. And with the internal carotid terminus ICAT occlusion, it's even less at about less than 10%. So many of these patients, even if they receive thrombolysis, aren't recanalizing. And this is a study from kind of an older study from 2011 out of Stroke by Rydell et al. And it was looking at how thrombus length affects success in recanalization. And I looked at 131 patients with acute ischemic stroke due to MCA occlusion who were treated with IV TPA. They measured clot length and then looked at the rates of recanalization. And you can see here that in the patients who had clots that were greater than 7 millimeters long, these patients were never opened with TPA. They all had persistent occlusion. So we needed to find other ways to treat these patients who either weren't qualifying because of time, weren't qualifying because of being on anticoagulation, or weren't qualifying, or they received lytic, but they weren't recanalizing. And so this is kind of a timeline of endovascular thrombectomy for acute ischemic stroke. You can see some of the early device trials here, some of the early negative trials, but are really endovascular thrombectomy became standard practice after these positive EVT trials in the Hermes collaboration. So Mr. Clean, Escape, Extend, Revascat, and Swift Prime. And they showed benefit of thrombectomy in up to 12 hours in one of the trials. And then in the Hermes meta-analysis that was performed in 2016, they discovered that the number of patients needed to treat to have one good outcome was less than 3 patients. So you can see that that's much better number needed to treat compared to even thrombolysis. Then in 2018, the Dawn and Diffuse trials showed a benefit of thrombectomy out into the extended window. And that's what we'll be focusing on today. And then since then, we've had further trials that have showed kind of some special cases. So there was consideration, should we be skipping thrombolysis in these patients who are at an endovascular capable site and going direct to thrombectomy? The European Stroke Organization did a meta-analysis of the trials looking at this and found that they couldn't demonstrate non-inferiority by doing skip. So the recommendation is to continue administering thrombolysis to these patients, even if they're at a thrombectomy capable site. Here are the vascular trials. And then more recently, we've been looking at whether patients with large core could benefit from endovascular thrombectomy. But today we'll be kind of focusing on the Dawn and Diffuse 3 trials. So we'll start off by kind of talking about who qualifies for treatment. And before we do, I would just want to review some of the clinical and imaging scores that we use for inclusion and exclusion in the thrombectomy trials. You're all familiar with the NIH stroke scale score that was initially developed as part of the NINS trial for TPA, but is still used in thrombectomy trials currently. Really, we're focusing for thrombectomy on these patients with moderate to severe strokes, generally an NIH of 6 or greater. Here is the Alberta Stroke Program Early CT score or aspect score, which I know the sites I've spoken with are very familiar with. And basically what we're looking at is plain CT at the level of the basal ganglia and then just above the ventricles. And there are 10 key regions that are evaluated on a plain CT scan. You start with a perfect score of 10, and then for every area of hypoattenuation or kind of dark area on the CT, we subtract 1 point. So aspects of 10 would be a case with no ischemic changes, and then diffuse ischemia would be an aspect of 0. Here's an example. So a normal scan here, And this would be an aspect score of 4. Other ways that we can quantify kind of how much the ischemia has progressed in acute stroke is a DWI flare mismatch. So you can see here, this is what we consider a favorable mismatch, where there are DWI changes, but the flare has not shown changes yet, versus an unfavorable, where the DWI and the flare are well matched. At our sites, we are using perfusion imaging. And so this is a CT Swift Prime perfusion with rapid software. And basically, the area that's pink here represents the core, the ischemic core, so areas of tissue that have irreversible ischemia. And then the difference between the pink area and the green area is what we'd consider salvageable tissue, or penumbra. And so basically, we kind of look at a mismatch between those areas. So the top picture here is one study that would be considered a favorable mismatch. You can see that the volume of irreversible ischemic change is about 9 milliliters versus 126 milliliters here. And the mismatch is what we consider favorable. So there's a lot of ischemic tissue that is potentially salvageable. And then in this bottom picture, this would be considered an unfavorable mismatch, where there's a large core volume of 176 milliliters and a similarly large penumbra, but the mismatch would be considered unfavorable. So what if you don't have rapid software or perfusion scan at your site? One option would be to use multi-phase CTA to evaluate collaterals, and this was done in the ESCAPE trial in Canada, where they perform a traditional CTA or conventional CTA on the first scan. Then they go back and they do mid-venous phase scan, and then they go back and they do a late venous phase scan. You can see those phases here. There's a few examples. The top case would be an example of a case that has good collateral flow. You can see it in all the different phases, versus here at the bottom. This would be a case with poor collaterals. You can see there's a right M1 occlusion, and in these later phases, there's no vessels lighting up on the scan, or limited vessels lighting up on the scan. So when we think about thrombectomy trials, we grade our success using angiography, and we know that these grades correlate with long-term functional outcomes. So we use something called a TICI score. Basically, what we're looking at is what percentage of the territory that's involved is filling, and is it normal filling, or is it delayed slow filling? And so I would consider a successful case to be a TICI 2B or better. So at least 50% of the territory filling, even if it has some slow flow, like we'd see here in TICI 2C. And then another kind of important definition to be familiar with is how we define symptomatic intracranial hemorrhage. And that's going to be, most of the trials are using a greater than or equal to 4-point increase in the NIHSS within 36 hours of treatment due to hemorrhage. And I think most of the trials we are looking at today use the ECAS definition. And then in terms of kind of clinical outcomes, depending on the trial, some use non-disabling versus disabling. Some use good outcome versus poor outcome. Most of our data, we're using the good outcome versus poor outcome. So an MRS modified Rankin scale of 0 to 2 would be considered a successful outcome in terms of functional status. And basically, the modified Rankin scale is looking at how much disability a patient has and how much they're reliant on either devices or others to carry out their daily activities. So this was the
ចាស់ត្រឡប់ទៅដំបូងរូបភាពវាអត់ទាន់ចេញជាស្លតតែនេះ
think the network down, open the microphone.
oh,
ขออนุญาตปิดไมค์ด้วยค่ะ มีเสียงเข้าค่ะ โอเค
So kind of going back to those early thrombectomy trials, these were the 5 main. There's also Thrace and a few others, but these were all released in 2015, and they included patients who had a last known well, mostly 6 hours, but some went out as far out as 12 hours in terms of the last known well. And the different trials use different imaging criteria. Most used an aspect score to quantify whether or not someone was a candidate, and using an aspects of 6 or greater. The escape trial did use a collateral score with that multi-phase CTA that we looked at earlier. And then Extend and Swift Prime used a combination of those as well as rapid. You can see that with our Hermes collaboration, the outcomes with endovascular thrombectomy for acute ischemic stroke were excellent. They all had significant positive effects. So you can see for Mr. Clean, endovascular thrombectomy, 33% of patients had a good outcome of modified Rankin of 0 to 2 at 90 days compared to 19% in the controls. And then the strongest positive effect was in Extend, with 71% of patients having a positive outcome compared to 40% in the controls. So these studies all showed that the number needed to treat for independence at 90 days was as good as 3. So potentially for every third patient that we're treating, they're function independent at the 90-day period. And so with a treatment that's so effective, potentially more effective than thrombolysis, how can we capture more patients who can benefit from this procedure? 40% of LVOs are wake-ups or have an unclear last known well or are late presenting outside of that 6-hour window. So how can we better capture those patients? So kind of after these trials came out, there was a registry, the Trigo registry, that was in 2016. It looked at 1,432 patients. 969 were treated within the 6-hour window, according to guidelines at that time, but 462, or almost a third of the patients, were treated outside of the 6-hour window. And you can see here that the MRS of 0 to 2 was achieved in 53% of patients who were treated outside of the standard window at that time, compared to 55% in the what was at the time accepted as the standard window. And so why is that even these patients who are outside of that early window are benefiting? Well, we're finding more and more that rate of stroke evolution is highly variable depending on the individual patient. And part of that may be related to collateral circulation, among other things, but we're learning more and more that time isn't the only determinant. So some patients are what we call fast progressors, meaning they show hypodensities early on their scans, and others are very slow progressors, where it takes a lot longer for them to show ischemia on CT. So this is an example of a patient with time of last known well at 2.5 hours, and you can see they already have a quite large hypodensity, even though they're at 2.5 hours from last known well. This one was at 6.5 hours, which is quite remarkable, I think, that they have that much mass effect and that hypodense of a region. But then here you see one, this is also a large vessel occlusion at 30 hours, and they have pretty minimal area of hypodensity. So we can see that the evolution is not only time dependent. And so there were 2 trials that came out in 2018 that kind of looked at this question of can patients with large vessel occlusion benefit in that extended window out at the 6 to 24-hour window? Kind of starting with Dawn, this was a trial looking at 50 sites in the US and internationally. They had 500 subjects, 250 in each arm, and basically they were testing the hypothesis that patients with acute ischemic stroke due to occlusion of the ICA or M1 with signs of salvageable tissue and clinical imaging mismatch would benefit from thrombectomy at 6 to 24 hours. And patients were randomized to either endovascular thrombectomy with a Trevo device or medical management. And so here you can kind of see the inclusion criteria. They did use MRS of 0 to 1 for their inclusion, and they had a little bit higher NIH than most of the thrombectomy trials for inclusion, NIH of 10. And then you can see the qualifiers here for imaging. So they wanted to see less than 1/3 of the MCA territory involved on plain CT or on DWI. CTA showing either ICAT or M1 occlusion. They did permit tandem occlusions in the trial. And then they had different rapid criteria depending on the patient age. So for patients who are greater than 80 years old, they had an IHSS of 10 and a core of less than 21 cc's. And then for patients who are less than age of 80, an IHSS of greater than 10 and core of less than 31 cc's, or an IH of 20 and a core of less than 51 cc's. And then they were randomized to either medical management or medical management plus thrombectomy. And they looked at a utility weighted MRS and a nested MRS of 0 to 2 at 90 days. So those are the endpoints. They did have some secondary endpoints, including early decline, all-cause mortality, infarct size, which generally isn't the best measure for study, and then revascularization rate of TICI-2 perfusion. Safety outcomes, they looked at stroke-related mortalities at 90 days, and then they had some secondary safety endpoints, most importantly, I think the symptomatic ICH. So you can see the trial was stopped early based on the recommendations of the Data Safety Monitoring Board because of the positive effect. Going through just some of the demographics and clinical presentations of the patients who were included. Both groups were really quite well matched. One kind of interesting point was that the treatment arm in Dawn did have a significantly higher number of patients who were wake-up strokes. So waking up with symptoms without a clear last known well compared to the control arm, and that was significant. And then in terms of the baseline imaging characteristics, they did use rapid, and about 60–70% of the patients used that for their qualifying inclusion in the case. And most of these were M1 occlusions that were fully occluded. You can see here that the control arm, it was a little bit mismatched in terms of the control arm had more patients who had received thrombolysis compared to the treatment arm. And their success rate was pretty typical. I'd say so. Their success rate was 84% in terms of recanalization. So TICI 2B or better in 84% of patients. And the trial specified that they were to stop after 2 passes. So they kind of capped out at 2 passes. And you can see here the results. So 90-day MRS of 0 to 2 for the Trevo versus medical management group, and kind of based by last known well. So in the 6 to 12 hour window, you can see that 55% of patients achieved MRS of 0 to 2 at 90 days, compared to the medical management group, only 20%. And that was significant. And then that treatment effect persisted throughout the 24-hour period. So 43% of patients who were treated with Trevo had MRS of 0 to 2 at 90 days, compared to 7.4% in the medical management group. But again, the earlier we reestablish blood flow, the better the outcome. And so the number needed to treat for independence at 90 days for the Dawn trial was 2.8. So they found that for every 100 patients who were treated with endovascular thrombectomy, 49 would have a less disabled outcome as a result, including 36 who would be completely functionally independent. And this was the Dawn trial had the strongest treatment effect in terms of stroke trials at the time. So yeah, it's really one of the biggest landmark trials, I'd say, in stroke. There was a similar trial that was going on at the same time out of a group, I think primary author was out of Stanford, called Diffuse 3. Similarly, their hypothesis was that patients with MCA or ICA occlusion in salvageable tissue would benefit from stroke at 6 to 16 hours. So it was a little narrower of a window. They randomized patients to thrombectomy versus medical management. And they again used 90-day MRS as their endpoint, with a primary of the ordinal shift, and secondary was the MRS of 0 to 2. The inclusion criteria for this study, age 18 to 90, NIHSS of greater than 6, premorbid MRS of 0 to 2, and they had to have femoral puncture within 6 to 16 hours. And then for the imaging criteria, they used aspects of 6 or greater, M1 or ICA occlusion. They used a core volume of less than 70 for the ischemic core with irreversible ischemia, and then a mismatch ratio, so the difference between these two areas of greater than or equal to 1.8. You can kind of see some of the patient characteristics here. Again, a pretty well-matched study. And they performed an interim analysis after the Dawn trial was released, and it was stopped early. But you can see here that the endpoint of MRS of 0 to 2 is achieved in 45% of patients who received endovascular thrombectomy, compared to 17% who received medical management alone. And while the rates of symptomatic intracranial hemorrhage were higher in the endovascular group, they didn't achieve statistical significance. And even so, this is a similar rate to the symptomatic intracranial hemorrhage rate in the NINS trial, so for TPA. And then the mortality was also significantly lower in the endovascular group at 14% compared to 26% in the medical group. So you can see kind of some of the kind of comparison of the Dawn and Diffuse trials in terms of their inclusions for last known well. One went out to 24 hours, the other out to 16 hours. Diffuse did use aspects, which I think will be applicable at your sites, as it sounded like most aren't doing perfusion studies at this time. And so based on the results of these trials, the American Heart Association and Stroke Association guidelines were updated in 2019 to extend the window the recommended window for thrombectomy out to at least 16 hours was a strong recommendation, and then in selected patients out to 24 hours. And they did recommend use of the eligibility criteria for DAWN and diffuse 3 when implementing that extended window. And then after these trials came out, there was a study published in Lancet that looked at kind of all the trials at the time that were in the extended window. So the Aurora meta-analysis looked at 500 LVO patients with last known well at 6 to 24 hours. The mean time from last known well was about 12 hours in this study. They included DAWN patients, diffuse patients, and then resilient, positive, and revascant. And the primary outcome was ordinal shift MRS at 90 days, and it strongly favored thrombectomy. The MRS of 0 to 2 favored thrombectomy at 45.9% of patients achieving that outcome compared to around 20%. MRS of 0 to 1 favored thrombectomy with about 28% of thrombectomy patients achieving MRS of 0 to 2 or 0 to 1 compared to the control. And there was no significant difference in mortality or symptomatic ICH. So these are kind of our accepted practices, I would say, in the States in terms of qualifying for thrombectomy at this point. So patients need to have a baseline modified Rankin scale score of 0 to 2, last known well within 24 hours, NIHSS of 6 or greater, aspects greater than or equal to 6. And then we are using perfusion imaging with a core volume of less than 70 and mismatch ratio greater than 1.8. And we kind of already talked about this, but what are some options if you don't have access to rapid software here? You could consider using that aspects again of greater than or equal to 6, and then using a collateral score with the multi-phase CTA. And the kind of criteria that was used in ESCAPE was that you should have at least greater than 50% MCAPL arterial circulation filling. We'll just kind of quickly go through a clinical case, and it's a 65-year-old man who was previously healthy with the exception of unintentional weight loss over a two-month period. His last known well had been at around midnight, and he was found at 8 a.m. with left hemiplegia and right gaze deviation. His NIHSS exam score was an 11. Here's the imaging from the outside hospital. We know that syndrome is locally seen to the right MCA territory. There's maybe some early ischemic changes here, so maybe an aspects of 7 or 8. And then you can see here that there's a kind of hard to tell in a non-scrolling image, but the right M1 occlusion. So the patient was transferred to OHSU for consideration of thrombectomy. You can see maybe a little more clear hypodensity there on the plain CT. But then look at his perfusion scan. No ischemic score on the in the CDF less than 30% volume, but there's this huge penumbra with an infinite mismatch. And this was done at 10:48 a.m. There's the last one. So ART-SIC was performed at 11:25. You can see there's persistent occlusion. But this patient had a lot of collaterals that were supporting that penumbra. Device deployment was at 11:39. And at around 11 hours from last known well, they were able to achieve TICI-2B reperfusion. The patient did end up having hemorrhage within the kind of initial territory that we saw some possible hypodensity on the plain CT, but it was asymptomatic, so did not count as a symptomatic intracranial hemorrhage. And at 48 hours from the procedure, his NIHSS had dropped from an 11 to a 0. So you can see, that this was a patient who received treatment at 11 hours and had a really ideal outcome. So extending the time window from the initial 6-hour window to the 24-hour window does increase the number of patients that need to be screened, but it also results in a lot more patients receiving effective treatment for their stroke. So one study I was looking at suggested that the number needed to screen to find one EVT eligible patient in this window would be about 8 patients. But it results in about a 26% increase in patients receiving EVT and a 36% increase in good clinical outcomes of independence. What about some future practices? Extending it to more patients. So does extended window thrombolysis benefit patients? The Timeless trial, also based out of Stanford, looked at patients who were having an acute ischemic stroke due to MCA or ICA occlusion and had evidence of salvageable tissue on perfusion imaging. They were prescribed tenecteplase or placebo in the 4.5 to 24-hour window, so outside of our traditional window. And they looked at ordinal MRS at 90 days, safety outcomes of death and symptomatic intracranial hemorrhage. They enrolled 458 patients, and the median time to last known well was about 12 hours. And the conclusion was that the tenecteplase did not result in better clinical outcomes compared to the placebo. The incidence of symptomatic intracranial hemorrhage, though, was about the same in both groups. So we are not incorporating this into our practice. So what about how can we extend the amount of patients who qualify for EVT in that extended window? What about these patients with larger core stroke? So there have been more trials that have looked at large core thrombectomy since these two initial, but I think these two are kind of interesting to review. The Angel Aspects and Select 2 trials published in 2023. You can see here Angel Aspects, New England Journal of Medicine. It was looking at patients who were under the age of 80. This is kind of a key feature of their inclusion, who have MRS less than or equal to 1 at baseline, NIH of 6 to 30, and acute ischemic stroke due to ICA or M1 occlusion, and then a large core, which they defined as either an aspects of 3 to 5, aspects of less than 3, but with core of 70 to 100 on perfusion imaging, or an aspects greater than 5 and a core of greater than 70 to 100 cc's on perfusion. Patients were randomized to either thrombectomy and medical management or medical management alone. And
one moment please ขอโทษนะคะ มีเสียงแทรกอีกแล้วโหมดปิดใหม่
And they found that with the ordinal shift analysis that it favored performance of EVT over medical management alone. And I really like to look at the MRS, looking at functional independence. And then also I like to look at independent ambulation because I think that really affects patients' quality of life. And you can see there's a significant reduction from 12% in the medical management alone to 30% of patients achieving an MRS of 0 to 2 with medical management and endovascular thrombectomy. And the trial was stopped early because it crossed the efficacy boundary. So they felt like it was no longer ethical to continue not treating these patients. Here you can see the ordinal the MRS shift. So you can see it strongly favored endovascular thrombectomy. Here's patients MRS 0 to 2, 0 to 2. And then there were similar results for the SELECT-2 trial and favoring thrombectomy for these large core patients over medical management alone. The number needed to treat to achieve functional independence was significantly higher than for the other thrombectomy trials. It was around 7.6 compared to around 2 or 3 with the smaller core, but still potentially beneficial. And the risk was minimal. There were very few cases of symptomatic intracranial hemorrhage. And this was also stopped early for crossing the efficacy boundary. And you can see that the median aspect score in this trial was aspects of 4. And on perfusion, the median was 80 cc's of core volume, but they did go all the way out to almost 120 in terms of their food. Really kind of typical, success rate around 80%. And pretty minimal procedural complications. And they looked at kind of a subgroup analysis. Again, the trial's not powered to look at these questions, but the benefit persisted. It was stronger in the younger, stronger in the MCA patients. And you can see that the benefit persisted across all time window. And here are those higher volumes for cases here. Kind of interesting that the smaller core crossed. Yeah, here's kind of a summary of these trials, looking all the way out to the 24-hour window, and you can see that they were using aspects for as low as 3 and cores as high as 100 cc's. So the kind of takeaway that we've taken from these studies is that patients with acute stroke in the anterior circulation, thrombectomy plus medical management resulted in more patients achieving good outcomes compared to those receiving just medical management alone, and that we can potentially significantly increase the number of patients who are able to achieve functional independence. So at our institution, we've kind of made some adjustments to our inclusion criteria. Again, it's a case-by-case basis, but this is kind of what our interventionalists and ourselves have settled on as like kind of a starting point in the conversation when we're looking at patients off guideline. So they still need to have a premorbid MRS of 0 to 2, still need to have an NIH of greater than or equal to 6. We've lowered our aspects criteria down to aspects of as low as 3. And our core volume that we will accept is out to as high as 100 from 70 before. And then we're not using mismatch as much anymore, but are more looking at, is the penumbra in an area that has eloquent tissue? Is it in an area that's affecting language or strongly affecting motor function? And so this is generally what we've been using for selection, and we're really only doing it for younger, very healthy patients and are very carefully selecting. But we did have a case that really stands out in my mind, a 28-year-old male who came in with an aspects of 3 and severely debilitating deficits. He underwent thrombectomy. It was with successful reperfusion. And he comes to see me in clinic now and walks in, schedules his own appointments. He's back at work with an MRS of 1. So that's a patient who previously would not have qualified for treatment based on guidelines, but has now a whole life ahead of him that he wouldn't have had before. So we're hopeful that with all these new trials that have come out, that we'll have more guidelines to guide us as to what is accepted kind of on a nationwide basis. They did just come out with a new primary prevention guideline about a week or two ago. But the new acute ischemic stroke guidelines aren't slated until Q4 of 2025. So we're anxiously awaiting those guidelines. And those are my citations. Thank you so much for listening.
Thank you very much. Any question from the floor for Dr. Lawson before we move to Sarah's lecture?
May I ask two questions?
Yeah.
You talk about in your OSSU new guideline about less than 75 years old, but most of us coming to the stroke fast track more than 80 years old. What is the?
This is just for the large core.
I
If they have a large core, we aren't doing that procedure for older patients because it's off guidelines, but we're performing thrombectomy based on the standard guidelines all the way out to even a very healthy 90-year-old might qualify for.
The second thing is about we don't use aspect score. We use MRI. So it's difficult for our team to aspect score. What is the clarify? Even the neurologist reluctant to say that it's aspect score, the MRI aspect score not compatible with CT aspect score.
Is that only at Bangkok International, or some of the sites were saying that they are using aspects? Is there a lot of variability in terms of?
I think in large core study in some hospital they use the MRI aspect score also.
Yeah.
But for here we use just eyeball to say that what is aspect score.
Yeah, that's what we do too. So it's rated by a neurologist and the interventionalist. We both review it and kind of come up with scores independently and then kind of compare or disagree. So yeah, our neurointerventionalists and stroke neurologists both come to the scanner when a patient is fast tracked, if they're being transferred from another hospital. And so most of our thrombectomy cases are transfers. And so there's time for the interventionalist to get there. We review it together at the time that the scan's being done before it's read by neuroradiology.
I think you also use Rapid, right?
We do. We're using it, I would say, less and less and relying more on the aspect score at our facility, especially with these newer trials that are kind of suggesting that maybe a perfusion scan is less relevant than we had initially thought. And it is subject to different artifact as well. So.
And the last question about the patient more than 80